without much further ado, Jim Capretta on defined contribution route to healthcare reform.
Thank you very much. Well, Tom, obviously of all the roles I play, my favorite is co-author with Tom Miller because it's so lively and entertaining. But I do appreciate Tom inviting me to be a part of this Beyond Repeal and Replace project. I think it's very important to have a conversation and start thinking about what healthcare could look like in an alternative reform program. Because it really, I think the last conversation about the minimum loss ratio was very instructive. That there's something now in place, and it's unstable for all the reasons Tom went through in his initial slides, politically and substantively. But it is in law, so people are starting to create worlds around it. And so there's, we have a lot of work to do to put in place something that would be different. And so that's why I think this project is very, very important. Now, my assignment with Tom was to talk about defined contribution, and that needs a little bit of a predicate for why we're talking about that. In this first slide, the slides really just summarize the thinking that goes into the paper. So they're very top-level slides and not a lot of detail in them, and I'll just try to elaborate a little bit on them. From my perspective, the central question that was at stake in the healthcare debate, and really still is at stake, is what to do about slowing the pace of rising costs. Yes, there's an issue of how to go about covering more people with insurance, but I would argue there that even Senator McCain's proposal from the 2008 campaign was really a universal coverage plan in itself. It was really at stake here is a question of what to do about cost control. And there are two schools that do have some intersection but largely don't overlap. One is sort of a top-down approach where the government gets much more involved in trying to engineer how healthcare operates through a variety of mechanisms, and by doing so, hopefully create more efficiency throughout the health sector. And that's the theory of much of what's written into the Patient Protection and Affordable Care Act. And the alternative to that is, of course, a functioning marketplace. Now, before getting to what we need to do to build a functioning marketplace, it's worth spending a moment on why the alternative actually won't work. I've done a fair amount of work on this, of course, over the last 2 years of the debate, but and repeated this many times, but it's always worth going into a little bit just to make sure everybody's on the same page here. The primary argument of the Patient Protection and Affordable Care Act is that through CMS and through HHS, they can use a number of different levers to literally rearrange how hospitals and physicians interact with each other and make those arrangements more efficient, painlessly more efficient, so that they're delivering higher value for less cost, and in effect bringing about more productivity in the health sector. Now, this is not a new idea. CMS has been trying to do this in Medicare, through Medicare, for a very long time without a lot of success. And one of the main reasons is that to build a high-value health system, you actually have to pick and identify who is a low-value provider. In other words, to build a network of high-value providers who are delivering high-value care, you got to identify those who are delivering low-value care, right? And then you got to exclude them. Okay, you got to kick them out of the network, basically. And the ability of the federal government to do that is approaching zero. And the reason is, there's a little anecdote that I like to tell. This is painful for Joe, but Joe Antos over there. But the federal government 20 years ago started a project on centers of excellence, and they put their toe in the water through the Medicare program, where they were going to identify hospital systems that were performing at a high level on certain high-volume surgical procedures, mainly heart procedures. And by doing so, put their toe in the water, identify them first as centers of excellence, and then, maybe a year or two later, after they're identified, start to steer the Medicare patients away from non-centers of excellence to centers of excellence and drive volume to the high-value, low-cost systems. And so they start to go down this road, and I think that the label actually still probably exists somewhere in CMS. But they got a year or two into it, and of course, immediately anyone who wasn't on the list, and there were some very prominent ones who weren't on the list, said, hey, there's something wrong here. You know, you went through this whole process, and your data's lousy, basically. You didn't properly risk adjust it. We got a lot sicker heart people in our hospital than they do at the one 100 miles down the road, so we don't believe your data. Certainly the 100 miles down the road is not a center of excellence. We are. And so, you know, big brouhaha ensued. Lots of people went to the Hill, and the thing pretty much died in its you know, infancy. Never really got off the ground. And so they never really moved forward with it. Now, I bring that up because when you look at the bill, despite all of the talk of engineering a better healthcare system through accountable care organizations, through the Independent Payment Advisory Board, through health information technology and comparative effectiveness research, all of these I think are part of this web of things they're planning to try to pull to steer the delivery system toward more efficiency. Almost none of that has been expected to save any money, really. It's very, very minor in the scheme of things. The way they saved a boatload of money was by cutting everybody the same across the board. They didn't distinguish between hospital systems. They didn't distinguish between clinics or labs or anybody else based on quality. They just paid them all less. Okay? And that's the history of Medicare. That's the history of cost control in the federal government, by the federal government. And the result is not that you have any refining of the delivery system. In fact, what you end up with is more perverse incentives and, quite frankly, more fragmentation, more emphasis on volume, and all of the reasons why we have problems in the delivery system. Essentially, a lot of it emanates from this kind of cost cutting. And the bill does it in spades. It doesn't roll it back. It actually does more of it. Okay? So the idea that somehow after another few years of trying more research, more effort, more innovation through CMS, that this is going to somehow get us better at doing this, I think is really a long, long shot. The fundamental problem is it's easier for a politician to cut everybody the same than it is to go back to his district and pick winners and losers. It's easier for them to go back and say everybody's going to get a 5% cut than it is to go to a hospital and say you're out. Okay? And that's fundamentally the problem in the delivery system. Now, the alternative to that, of course, is building a functioning marketplace, which is no mean feat either. Okay? And that's really the subject of much of what the paper is about that I've written here with Tom. And why is it so difficult to build a functioning marketplace? Well, the missing ingredient, the fundamental thing you have to have in a functioning marketplace to allocate resources efficiently is cost-conscious consumers. You have to have people that are on the margins worried about spending some of their money on something of low value. And so you have to then look into the health system and say, do we have that? And the answer is, I think, basically no. You have it to some extent in some places, but more or less on the margin, when an extra dollar is in question, the answer is no, because most consumers are largely insulated from the costs of that extra dollar of consumption by who else? The federal government. Okay? And so when you then dig in and say, well, what's that all about? Well, think about it this way. The vast majority of Americans get their health insurance really through three sources. Through either Medicare, which is roughly 45 million people, through Medicaid on the acute care side, that's in the order of 50 to 55 million people, and then through employer-sponsored insurance, tax-preferred employer-sponsored insurance, which is on the order of 160 to 170 million people. Okay? The rest, if you're not in one of those programs, you're in either military health care or you're uninsured, basically. Okay? In each of those instances, through Medicare, through Medicaid, and through the employer-based system of insurance, when an extra dollar of premiums is paid on behalf of one of the enrollees, the federal government is picking up a sizable proportion of the tab. In the Medicare context, it's roughly 40% through various general taxpayer subsidies through the general fund of the program. In the context of Medicaid, the federal government picks up 60% in rough terms of the tab for every extra dollar spent, and then states pick up 40%. So the states that are designing the program only get to save 40 cents on every dollar if they try to cut back on spending. The federal government's picking up the rest of the tab. And by the way, both of these are open-ended. There's no limit on it. Okay. The third being, of course, the tax-preferred status of employer-paid premiums. And in rough terms, for a middle-class family, for every extra dollar spent, it's roughly 40% of it is subsidized by the Treasury. Okay. So in each of these cases, you've got, and it's open-ended as well. There's no limit to the amount. Now, that may change with the Cadillac tax to some extent, depending on how you think about it. But more or less, today's terms, each of those is open-ended. The federal government is spending a lot of money to provide ever greater cost in insurance. Now, the antidote to that, at least as Tom and I have talked about this, is that we need to move away from open-ended subsidization of each of these programs to build a functioning marketplace. And the subject of the paper is to think about it in each of these contexts, in the Medicare context, Medicaid, and employer-sponsored insurance, but also to think about some of the connections and platforms that could be usable across all three. Okay? Because if you move across the board, there's potential for obviously some synergy here, and also some sharing of constituencies, so that maybe the constituencies that are in each bucket don't always stay in those buckets as they move around. Now, we've talked about moving in this direction toward defined contributions for a very long time. Pro-market reformers have pushed consistently to close off the open-ended federal subsidization of these programs. And I apologize, a couple of words dropped off this slide through some of my fault there. But basically, the point I wanted to make on the last bullet there is this approach provides both stronger budgetary control. Okay, so instead of providing an open-ended subsidy for each of these, you've got a defined amount that the budget can account for and maybe budget for and plan for in the coming years. And also it has better incentives, right? So at the margins, every consumer, instead of getting an open-ended entitlement, is going to get some fixed amount from the federal government, and that, of course, then gives them an incentive to economize in what they're consuming. Now, when people ask, well, is this really a feasible thing? I think in the healthcare context, it's obviously quite difficult. If it was easy, it would have been done some time ago. But one thing to keep in mind is there has been a revolution, at least on the pension side, in American retirement security. It's not that long ago, 1985, when 80% of all full-time workers were enrolled in defined benefit pension schemes. 80%. And of course, we all know that that's basically gone now. It's down to 20. And those are basically in unionized industries. The vast majority of American employers have moved rapidly away from open-ended pension commitments over the last 3 decades. And even in the government setting, both at the federal level, the federal government moved away from it in 1983 when it closed off access to, at least in part, not totally, but in part, closed off access to the old civil service retirement system for new employees to the federal government. And state and local governments are doing it as fast as they can, closing off enrollment to their old defined benefit pension schemes. Now, these are all tough things, and they involve long tails in terms of transition periods. But it's not out of the question that a big change in the social contract can be done with a lot of effort and a number of levels, employers as well as the government. Now, whenever this topic comes up, someone will say, well, does such a thing exist in nature? Is there anything that really comes close to this at all? And the answer is basically we have some cousins to what we really have in mind. None of them are big and huge and not national in scope. No country around the world does this in a way that I would say is a version that would be appropriately strong to actually bring about the kind of incentives you need in a functioning marketplace. But here in the United States, so far the best example we have of how this might look, at least in my mind, is the much maligned Medicare drug benefit. There's reasons why it's maligned. I mean, I worked on it when I was in the Bush administration, so I understand all the arguments, of why it may not have been an optimal solution. But I think, given that a drug benefit was going to be added to Medicare, the question of how it was designed was quite important. And given political realities, it's hard to imagine it coming out better than what it did. Okay, essentially, what happened was they said, "Look, we're going to deliver this drug benefit through private insurance competition only. The government's contribution to the insurers on behalf of beneficiary will be fixed based on the weighted average of the bids in a region, and a beneficiary will get that fixed amount. That's their entitlement in that region. If they select a more expensive drug benefit plan, they pay all of the extra amount out of their own pocket. If they pick a less expensive one, they get to save all of it and pocket the money." Okay, so you got pretty good incentives at the beneficiary level. The drug benefit had the advantage of not having a incumbent government-run plan sitting there that they had to deal with. So it was all from scratch, from the ground up, and that meant you could set up private-only competition with everybody on the same level playing field. There was no distortions from the government involvement in the drug benefit pricing. At the time it was enacted, there were all kinds of arguments that this kind of reliance on a decentralized defined contribution system would never work. Basically, it said, consumers won't be able to figure it out. No private insurers will participate. You'll have very anemic competition. Costs will be higher than if the government would just go in and negotiate directly with the drug companies, et cetera, et cetera. Lots of arguments. Go back and read the congressional record. When the thing was going on, everybody who opposed it basically argued that market competition in healthcare would not work. Okay? That was the argument. What happened? It worked. Okay? Basically, you had very strong incentives for the private plans to negotiate as good a discounts as they could get from the branded drug manufacturers, plus incentives to move as many people as possible into generic substitution, and much more so than probably if you went through the branded drugs, going to the federal government and negotiating with them, the lobbying, the effort that would go into that would probably have produced a more expensive benefit. And so costs have come in roughly 40% below original projections, which is pretty remarkable by government standards. Next. Now, the first thing then to tackle in this issue, and I think the most important one, is the Medicare program itself. I mean, I think Medicare, because of fee-for-service Medicare, is the one that it's creating all kinds of problems for financing the Medicare program, but it's also creating distortions beyond Medicare into the rest of the health system. And so of all of these, the ones that may be the most important to move off of an open-ended subsidization of insurance is probably Medicare. And in Medicare, it's important to realize that the system is quite distorted by the fact that you have a 1965 style fee-for-service insurance arrangement, really designed based on the way Blue Cross Blue Shield looked, 40 years ago. And the theory was, with fee-for-service insurance, the theory, of course, is that we will pay a claim. We will let the beneficiary essentially select who they're going to see for care at any given moment. So if they go to a licensed provider in a state, someone who's licensed to provide medical services to them, and it's standard medical care, then the insurer doesn't have to get involved in any of the medical side of the decision-making. They just pay the claim. And the way you kind of keep a check on use is through cost sharing. So you make the beneficiary participate, 20% of physician visits, a crazy scheme on the hospital side. But anyway, they have a system of cost sharing that's intended to be a speed bump on the way to use of care. Okay, making everybody think twice before they access care in a fee-for-service model. The problem, of course, is that Medicare isn't really that, because 90% of the beneficiaries have supplemental insurance of one kind or another. They have either through their state and local employers, through their former private sector retirement plans, through Medigap that they purchased directly, through Medicaid if they're low income. Roughly 90% of the enrollees in traditional fee-for-service Medicare pay nothing at the point of service. Okay, so now you've got a fee-for-service system where the insurer side essentially just pays the claims, and the beneficiary side at the point of service doesn't matter if they use 1 or 10 different procedures, still no cost to them. So there you've got very distorted incentives in terms of use. So it's very important to move away from that model, and that's feeding through the entire health system. The entire health system is built up around receiving revenue from the Medicare program. So it's very important that we take the model of the drug benefit and try to apply it in a broader Medicare reform approach. Now, for those of you who might be new to the health debates, and when I look around, there might be a few of you, believe it or not, this is also not a new idea. And it was actually got pretty close to being a viable reform program back in the late 1990s. There was a commission set up to look at Medicare reform, and they essentially came to the same conclusion that we should be moving away from Medicare as a claims payer and moving toward Medicare as a defined contribution program based on bids from competing private insurers. And it didn't get off the ground in large part because the Clinton administration didn't want it to. They basically killed the idea as it was trying to come out of a bipartisan commission led by Senator John Breaux, former Senator John Breaux. But the basic structure of it is not all that different from the way the drug benefit looks today. That is, you could set up in different regions of the country natural markets, not distorted micro markets, but natural marketplaces in particularly big urban areas and larger rural areas. Regions where beneficiaries would be aggregated together, and they would be plans would be bidding on providing the Medicare benefit package to them. The key here is that fee-for-service would have to be one of the bidders. Okay, as envisioned by the 1999 bipartisan commission, the fee-for-service system of Medicare would be divided up into regional administration programs surrounding these market areas, and premiums would be collected and aggregated region by region so that they cover full costs in that market area. And the payments by the fee-for-service program to the physicians and the hospitals providing services would have to be more reflective of market realities and rather than just government coercion. You couldn't just say, we're going to come in and pay everybody 5 cents on the dollar to take care of patients. It would have to have some relevance to willingness on the part of the physician community and the doctor and the hospital community to actually provide the care at the prices offered by the fee-for-service program. With that kind of a structure, then you would have less distortions in terms of the competition with the private plans, and you'd have a viable way of allowing, if people wanted to stay in the traditional program, even as you opened up the program to more competition and choice of plans. Now, in the employer context, this idea has also, again, been around for a while. In fact, Senator John McCain, when he ran for president in 2008, had as one of his centerpiece domestic policy proposals moving away from today's open-ended employer tax preference for employer-paid premiums toward a refundable credit that would be available to all households. Now, the important thing about this, if you remember back to that debate, I think it's very important to realize that what Senator McCain proposed, in my judgment, was a universal coverage plan. The press did not cover it as such, and the modelers, frankly, I think did a very poor job of estimating what would happen based on moving in this direction. But basically the concept here is you take something that is an employer-based tax preference and give it to every household in America, okay, regardless of whether they're paying taxes or not, and it would be a fixed refundable amount. Essentially, for taxpayers, a refund against your income taxes, but for everybody else who's not paying income taxes, a refundable voucher that would be used for health insurance. The key is could only be used for health insurance. Okay, so imagine this. Every household's going to have the dollar amount at that time was maybe $5,000, maybe it's now $6,000, indexed to something that would approximate some market mechanism. And if you didn't use this $6,000 tax credit, it would just sit there and go to waste. You would get nothing of value from it. So the response here, I don't think, is going to be millions and millions of households saying, I'd rather not. Okay? The response is going to be a supply response, people providing access to coverage, okay, and people saying, well, I'll use it for something. Okay? This is not going to sit there, and most households are not going to just let it go to waste. That's not been the experience, by the way, of the entitlement system in the United States, by and large. So, now, the other argument that was made is that, of course, that $6,000 isn't the same as $13,000 for family coverage. But, of course, this is a complete distortion of what's going on today. Yes, a family coverage costs $13,000 today, okay, and employers pay for it by and large, or 80 or 90% of it for a lot of employees. But the truth is that some of it's tax subsidized, but much of it is coming out of people's wages. So if you went to a refundable tax credit equal to the current tax preference for employer paid premiums, people would be no worse off than they are today. They would still be paying some of it out of their own pocket, but that would be paid for out of cash wages that they would actually get paid by their employer in a competitive marketplace. Again, that was lost in a lot of the attacks on the plan back in 2008. Now, I think one of the important things to keep in mind here is that if you move to this kind of an employer-based refundable credit or a defined contribution credit instead of an open-ended employer tax preference, there is the opportunity here for using platforms across both Medicaid and the employer-based system that would vastly improve options for Medicaid. Remember, today there is a complete lack of coordination between the Medicaid program and coverage for workers. Medicaid was essentially designed to be an insurance program for there's a lot of disabled people in Medicaid. Let's set them aside for the moment. Let's talk about the non-disabled in Medicaid. It was basically designed to be an insurance program that was separate and apart from the employer-based system for these non-disabled people who weren't working or working very minimally. The result has been that there's complete disconnects between the two. If you look at the uninsured numbers, a lot of the uninsured occur because there's churn between public insurance and Medicaid and the low end of the employer-based system. Someone is on Medicaid for a while, maybe they have their kids on Medicaid, they get a part-time job that pays more than they used to get paid, they lose their Medicaid eligibility, but they're not on employer-based coverage, okay? Then they lose their job and they go back onto Medicaid, okay? They're in and out, literally sometimes every 4 or 5 months, okay? So much of the problem on the low end of American health care is complete disconnects between different types of insurance coverage. If you move to a defined contribution system in the employer setting and do so similarly in the Medicaid program, have the federal government making defined contribution payments to the states for each Medicaid eligible person, you have new opportunities to coordinate the two and get them into portable insurance that they then stay with even as their income grows. Okay? One can imagine that something like the Utah health exchange that Tom's going to fix up in a future paper, that you can imagine something like a Utah health exchange where you have lots of small employers making defined contribution payments into an exchange on behalf of their workers, also being used for Medicaid for the same insurance plans competing. And as people then move between the two, they don't have to switch insurance. In fact, the whole thing could be very seamless on their part. It could be portable insurance that they stay with regardless of whether their income is going up or down. I think that could have tremendous work incentive potential, frankly, for people on the low end of Americans' economy. Frankly, if you look at the current bill, the law that just passed, the huge subsidies on the low end with the massive disincentives to get off of it are going to create tremendous sort of welfare lock. A lot of people are going to end up on these big subsidy programs with very little incentive to change, because they'll if they earn another dollar, they're going to lose their premium credits through the new exchange system. They're going to lose food stamps. They're going to lose housing vouchers, and they're going to lose EITC, and they're going to pay payroll taxes. So when you add all that up, they're facing marginal rates of implicitly of like 70 or 80%. And so you're creating a huge disincentive for people to actually earn their way up the wage scale another big problem with the health care bill. I think a lot of that can be solved if we go to defined contributions in the employer setting and supplement it with Medicaid that is gradually withdrawn, not abruptly withdrawn, so that people can have incentives to stay with the same coverage even as their wages go up. Now, a lot of times when people talk about defined contribution health care, they immediately go to its budgetary control. And Tom was right. I did work at the Office of Management and Budget, so I have that mark against me, I suppose. But and I do want to emphasize that if you move in this direction, think of it in the Medicare context. If you go to a defined contribution system with some element of budgetary control to it, instead of planning for disaster, you could plan for solvency and then adjust as we go as needed. Okay? And right now what we have is an open-ended system that is essentially planning for, on tens of trillions of dollars in unfunded liabilities, because it's open-ended and people know that creates huge incentives to spend. If you go to a defined contribution system, the attack is, well, you've shifted all the risk to the beneficiary population. Well, wait a second. Why don't we plan on making sure we can pay for everything we're going to provide? And if that turns out that that's pinching on the margins, a future Congress, a future political leadership can decide to increase it. But right now what we're doing is planning for national bankruptcy. And, I think obviously the prudent thing is to actually plan for solvency. And then as we earn and have more resources, we can provide more. That is all true about defined contribution. You get better budgetary control. But I think the key to understanding why it's important in the health sector is really not that. I think that's important. But the key is to think about it in terms of the health system effect. If you moved today's passive insurance enrollees, 40 plus million in Medicare, 100 and some million in the employer context, even some in the Medicaid context, out of today's system and into a system where they were given more of a fixed contribution from the federal government and the states and employers, and they had some choices that they had to make themselves, all of which involve either cost savings to them or maybe cost increases to them. You've now moved millions of people that are now essentially passive insurance enrollees into becoming active, cost-conscious consumers. I think that's the way. Instead of a top-down approach to trying to make the health system more productive, this would have the opposite effect, a bottom-up approach. The supply response would have to be there. You'd have to, if you didn't become more productive in the health sector, just like in the drug benefit, you would have great risk of losing market share to your competitors. Okay? If you want innovation on how to deliver more for less, I think this is the way to go. And there's evidence across many different markets where that's the case. I think I'll stop there and we'll go to the next.